accidentally, you know, a lot of people that are interested in snakebite, they kind of are interested in the animals. And although the animals are fascinating, I really came into it through the patient side. And back when I was a trainee, I trained with someone who was a real expert in the clinical care of envenomations, not just snakes, but scorpions, stings, and all other things. And that's how I initially got into it and began to do some clinical trials and some other work. In the meanwhile, I had done a fair amount of work on injury and trauma related stuff, and then kind of took that into the global health arena. And that's actually when the two kind of passions, I was able to marry those kind of the global health with the snake bite. You know, that's a great question. One is, if you look at my current position, there's administrative responsibilities, clinical work, and then the research. And I think the best way for me to integrate it is aligning the things that align well. Most of my clinical practice doesn't have much to do with snakebite, obviously. It has to do with emergency medicine. But my administrative job is to promote the clinical care and the academics of all of the Department of Emergency Medicine. So that can kind of align with both the clinical aspects of my job as well as the research aspects of my job. So I think the first thing to know, you know, there's this element of why Brazil, you know, why is that the place that we've chosen to do this? And there's a bunch of reasons for that. Some of that has to do around just snake bites. So the family of snakes and the families of snakes that they have in Brazil are actually the same as they have in North America. So just from the clinical standpoint, there's some relation, albeit the clinical presentations can be very different and much more severe, and the healthcare infrastructure is very different. They basically have two big families, and I'm going to use their common names just because it makes it easier. So the pit vipers, which are very similar, like a rattlesnake is a type of pit viper, cottonmouth, cottonheads, and then the species they're all pit vipers. And then they have coral snakes, a bunch of different types of coral snakes. And just like the US, the vast majority of their bites are from pit vipers, not from the coral snakes, which have a more neurotoxic presentation. They're a little bit different than the pit vipers that have like kidney injury and tissue damage and hemolysis, as well as coagulation abnormalities. So that kind of there is some relation to our experience in the US. So we bring some content knowledge to that, which makes it, you know, helpful. Although some of the things we're trying to learn will be applicable in other settings that have wildly different snakes, like, you know, monocle cobras and crates and different Russell vipers and all these other things. But that's so they tend to have more severe outcomes than they do in the US, but they're similar families of snakes. The biggest probably driver of why Brazil is, you know, this specific study that we're doing leverages some of the existing infrastructure of the country that already exists. So they have a nationalized healthcare system, and they have these clinical health community health centers. Now, those community health centers currently can't deliver antivenom. Those are delivered in referral hospitals. So the trick was they have a very strong group in Manaus, in the Amazon, the city of Manaus. They have a very strong tropical medicine group that we partner with. And so they have a lot of these elements, like a really strong group with all this expertise, this infrastructure, which currently is not being used, right, for this, and then nationalized healthcare. So some of the costing and costs are different. So it is a good place to start with this kind of work, so that we can make progress towards applying that. You know, Brazil is a middle income country, and we're working in a very low resource area of that middle income country. So then before you lever, having some success there, learning lessons there is part of a longer term plan to do that work in low income countries and low resource areas within low income countries. So it's kind of like we want to get a first down. We don't necessarily need to get the Hail Mary and the touchdown in the first shot. So those are some of the reasons that we're working in Brazil, and specifically the Amazon is because that's where the largest burden of disease for them is, and the most need around infrastructure and availability of antivenom. We're actually quite well down the road. So there's 3 aims, and we talk about a multimodal package. People can often get confused to think, well, the treatment is antivenom, so that's what we're talking about. But it's actually much broader than that. The multimodal package is actually all developed by all 3 aims. And I'm going to actually start with like the 3rd aim to describe that. So at the community health center, you can't just deliver. You don't have to sort through the grant model a way to deliver the antivenom most efficiently. You have to, that has to be attached to a clinical practice guideline, right? To how to use it, because those providers are unfamiliar or lack familiarity with how to use it. And that clinical practice guideline needs to be both developed and have some internal validation, but then also be externally validated by the people who are actually using it, and make sure it's meeting their needs and their perceived barriers that they would have to delivering the care. There also needs to be all the material resource around it, so refrigeration and all that stuff would have to be evaluated as well. So that's only part of Interim. That gives you an example of, it isn't just the antivenom, it's all the stuff around it. How do you deal with an allergic reaction secondary to antivenom? How do you deal with educating people on when to give those medications, making sure those medications are available, when to transfer to a higher level of care? So kind of the whole enchilada on what the community health center or CHC would need. And then the rest of the package is really like the kind of the where and the costing of it. So because these CHCs exist, we basically wanted an efficient way to decentralize the delivery of care, and to model what would be the most efficient next CHC to bring on board, right? And then you hit the sweet spot where bringing on additional community health centers don't really give you any more bang for the buck. And then to cost those models out, which is aim 2, and do a cost effectiveness analysis on where they should be. So as far as aim 1 goes, we're really far down the road on that one. And the process was kind of as follows. The first thing we had to do is attribute population. The goal was to get an individual who's bitten by a snake to a place that can deliver antivenom within 6 hours. And the reason we chose 6 hours is there's a lot of literature that beyond 6 hours, they start having worse outcome, because snakebite is a time-dependent illness, something we're really familiar with in emergency medicine. Absolutely. And we actually are using those trainings from a qualitative standpoint through like interviews to learn more about what, okay, now you've had some training. What deficits and what barriers do you perceive to you administering antivenom now? And I think we're getting good response. So that's a bit of an iterative process, of course. This is all preparatory for implementation, although there are elements of this package that you can implement without another grant, right? So we've already done the modeling of where they could go and all that kind of stuff. We've already done pilot trainings so there are people from a very small number of CHCs that now have been trained, but the actual implementation would be a standard full, higher level grant, and 4 or 5 year grant, and they could be evaluated as a more pragmatic trial, like a step wedge or something like that, which would allow us to bring CHCs on, community health centers on, and actually measure the true impact, because everything right now is just modeled. that is the $1 million question, of course, but we think so. I think one is important to know. So snakebite is primarily a tropical and subtropical diseases. So, if you look at a globe, it's pretty easy to see what parts of the world are impacted, and a lot of those are really resource limited. So I will tell you some areas that get quite a bit of snakebite, like Sri Lanka, for example, India, those countries, as well as sub-Saharan Africa has a lot of snakebite. I think one is Brazil is unique because it has state production of antivenom, and it has a nationalized healthcare system, and consequently has these CHCs. So the results of this would not be completely generalizable to another lower middle income country who doesn't have those. But it is a step in that journey, and I think we will have to come up with additional solutions for countries that are environments that don't have those resources. That being said, they may have other resources that Brazil does not have. So I think the lesson learned will be valuable, but it will never be plug and play. It will require some modification. I think one of the things that really attracted me to this idea is, antivenoms have been around since the end of the 19th century, right? So for over 120 years, people have been putting this into humans for snakebite. And yet we still have the kind of numbers that you see in the WHO report on the strategy for snakebite envenoming, which, are just remarkable, devastating numbers for those that are impacted by the disease. And so why is it we have this efficacious therapy that, oh, by the way, has gotten safer and safer and safer, and current modern antivenoms, they're really antibody fragments, are extremely safe. They're unlike the full body antibodies, the full antibody antivenoms that we used to use, like in the 90s, that I used in the 90s. So it's like night and day. They're just amazingly safe. And yet still we have this problem. And there's this big gap between efficacy and effectiveness, right? And that's what we are on a journey to solve. And the reason is the antivenoms are not getting in people. You can have this great treatment, but if no one ever sees it in a timely fashion because of transfer times, lack of infrastructure, or lack of knowledge, then it does no good. So in any case, some work is being done on novel agents. There's some really interesting, like small molecule novel agent. That work is really important. And some of those, or at least one of those, is trial right now, is in clinical trial. So it's in human studies. Most of this stuff is all preclinical, in the preclinical phase right now. And it's fascinating work. But even if one of those drugs, one of these novel agents, comes online in a way that we can use it, unless we solve some of these challenges with distribution and use, we'll still be in a similar problem. I will tell you the one that is being looked at most closely right now, the one is in human trials in the US and in India, that overcomes some of the gaps of antivenoms that can be delivered orally, for example, and it's cheaper to produce and all not such a complicated manufacturing process. But ultimately, you have to get it in people. And so I think this work, even if we come out with novel agents, it's going to be really helpful and is an important part of the strategy. And actually part that I'm hopeful that closing the efficacy effectiveness gap is a part that I hope that people will really focus on and value, not just the development of a novel agent, although that work is also important. Actually, we were able to navigate COVID pretty well. The biggest thing it had to do is it had to do with like team members that we had planned coming on board that were Brazilian and like that kind of stuff. There was some disruption, but because a lot of this was basically advanced geospatial artificial intelligence and using existing data sets, we were able to overcome a lot of those challenges by, kind of being innovative on how we guys are going to have to solve the problem a different way. So I feel like we're on track. We've made really good progress, and much of the work is in the manuscript or presentation phase, which is where we should be right now. So I think the message for the global health community is that some of the things we learn in snakebite are totally applicable to their research. And we have both taken work in other disease states and applied them in snakebite, and we are taking learnings and lessons from snakebite, and we plan to apply them in other diseases as well. So it's important for our group to closely follow other people's global health research. And I'm hopeful that our results can be mirrored in other people's work, whether or not it has anything to do with snakebite.